So let's move on to acute myeloid leukemia now. So here again, the myeloblasts are going to be more than 20%. Okay, so the Fab classification for this AML is going to be M0 to M7. So M0 is nothing but AML with minimal differentiation. M1 is going to be without maturation. M2 is with maturation. M3 is acute promyelocytic leukemia APML. M4 is myelomonocytic. M5 is monocytic. M6 is going to be erythroid, and then M7 is going to be acute megakaryocytic leukemia. Okay, in this M7 is going to be the least common, but it is going to be the most common leukemia associated with Down syndrome in age group of less than 2 years only. In general, it is ALL, less than 2 years, it is AML M7. So, whenever there is a megakaryocytic proliferation, it is going to be associated with fibrosis, because megakaryocytes usually produce PDGF, platelet-derived growth factor, and FGF, which can result in the fibrosis. So, marrow will be fibrous, and whenever there is fibrosis, if you do a bone marrow aspiration, you are just going to yield a dry tap. No cells are going to come. There is going to be a dry tap. Okay. So, what are the immunophenotypic markers to prove a myeloid origin? So, for lymphoid, we had already seen. So, to prove it is a myeloid origin, we have specific CD markers. So, first one will be myeloperoxidase. So, MPO will be positive. So, MPO can either be used as a special stain or in the CD markers in the flow cytometry as well. So, MPO is going to be positive. Apart from that, CD117, CD13 and CD33. You need to remember this. So, these are all the myeloid markers. So, we'll see about specific points about this Fab classification of myeloid leukemias. So, M0 to M3. So, all of this is going to be positive for myeloperoxidase. So, myeloperoxidase, especially, it is going to be much more positive in the APML subgroup. So, okay. So, M0 to M3, it is usually MPO positive, but the percentage of positivity will be varying among this. And M2 is going to be the most common of this AML. So, M2 is the most common, and it is going to be associated with specific translocation 821. So, 821 translocation, if it is present, you can call it as M2. And this M2 is most commonly associated with something called as scleroma. So, this scleroma is nothing but myeloblastoma. It has other name as granulocytic sarcoma also. So, these are nothing but leukemia cells, myeloid leukemia cells only, but they are going to be present in extramedullary sites like in skin. So, it is going to be present in extramedullary sites, then we call it as scleroma. It is given the name scleroma because it is going to have a somewhat a greenish kind of an appearance because of the presence of myeloperoxidase. So, because of the presence of myeloperoxidase in the myeloid blasts, it is going to have this characteristic greenish appearance, and they are called as scleromas. Okay, so this scleroma is going to be most commonly present in the orbit. So, in this picture, if you see, it is going to present with the proptosis. It is forming a tumor mass in the eye, leading to proptosis in the orbit. And microscopically, if you see in this scleroma, they are going to be composed of myeloblasts. So, that is a characteristic feature of AML only. So, these are myeloblasts only. So, whenever you see a scleroma alone without any peripheral blood myeloblasts, still you can call it as a acute myeloid leukemia. So, myeloblasts will be present. Along with that, you can see monocytes as well. So, these monocytes are given a special name as Arbuskov cells. So, this again have been asked in MCQ. What are Arbuskov cells? These are nothing but monocytes seen in a scleroma. So, M3 subtype is the APML subtype, right? Acute promyelocytic leukemias. So, here that characteristic translocation is 1517. You can call it as APML only when you see a translocation 1517. So, because of this translocation, there is going to be a fusion between PML and RARA. So, PML and RARA proteins are going to be fused here, and this fusion is going to result in the blockage of differentiation. So, there is going to be differentiation arrest at the stage of the promyelocytes itself. So, past the promyelocytes, they are not going to form myelocytes and then this metamyelocytes and band forms and neutrophils. Okay, so they are stopped at this promyelocyte level itself. So, this PML RARA fusion is going to cause differentiation arrest. So, what will be the treatment? You just have to give some differentiating agent which can remove this block so that the cells can move on to the next stage of differentiation. So, the specific treatment for this APML is going to be ATRA and arsenic trioxide. So, ATRA is all-trans retinoic acid and arsenic trioxide. So, both of these are differentiating agents which can remove this block. Okay, so this is specific. So, like CML, we have translocation 922, PML RARA fusion is for translocation 1517 is for APML, okay, and this is also treatable because we can give Atra and arsenic trioxide, while CML we had to use imatinib, okay. In APML, we have two variants. One is a hypergranular variant, another is a hypogranular or a microgranular variant. So, this hypergranular variant is going to be filled up with lots of granules in the cell, and this cell is going to have lots of OIR rods also. So, these OIR rods will be maximally seen in this APML, and they are going to form a cluster of this OIR rods, which we are going to call it as Fagot cell. So, Fagot cell is nothing but this cell. If you see, there is multiple rods, OIR rods, which are present in this cell, right? So, every cell of this is going to have this multiple OIR rods. So, this multiple OIR rods present in the cell, it is going to be called as a Fagot cell, which we see usually in a APML hypergranular variant. And these granules which are present in the APML are going to have a prothrombotic, they are procoagulants, and they are prone for developing into DIC, disseminated intravascular coagulation. So, in platelets also we saw this, right? So, the granules of the APML are procoagulants, so they can trigger excess coagulation resulting in DIC. So, in DIC, what will you see in the peripheral smear? Schistocytes, fragmented RBCs. So, whenever you get a peripheral smear for APML, apart from seeing this leukemia cells, you will also have to search for the schistocytes so that you can diagnose this DIC early. So, it is an emergency kind of a situation wherein you have to treat the patient immediately. Okay. And in this hypogranular variant of APML, you are going to see a buttock cell. The cells are going to be called as buttock cells because they are going to have this characteristic appearance like a buttock. So, where else do you see buttock cells? You can also see buttock cells in follicular lymphoma, because in follicular lymphoma, you are having proliferation of the centrocytes and centroblasts, and the centrocytes are actually having cleaved kind of a nucleus. So, these centrocytes will also have cleaved nucleus, and they also appear like a buttock. So, cleaved cells are also called as buttock cells. So, where all do you see buttock cells? In APML and then follicular lymphoma. Okay. So, this is the image of the buttock cell here. If you see, the nucleus is having this kind of a buttock shaped appearance, right? Either a reniform nucleus or a buttock shaped nucleus can be seen in APML. So, reniform means kidney shaped nucleus like this. Then moving on to M4, M5. M4, M5, whenever M4 is going to be myelomonocytic, while M5 is monocytic. So, any monocytic lineage, they are going to be positive for non-specific esterase. So, we have two types or two NSEs basically. One is neuron-specific enolase, which is positive in neuroendocrine tumors. And then another NSE is going to be non-specific esterase, which is positive in the monocytic lineage. So, both M4 and M5 are going to have some part of the monocytes. So, it is going to be positive for the special stain, which is NSE. And apart from that, the immunophenotype of these cells is going to be CD14 positivity and CD64 positivity. So, CD14 and CD64 are monocytic markers. Apart from this, so this M4, this is the myelomonocytic, right? So, there is a specific genetic thing involved here, which is called as inverse 16. So, inverse 16 is specific for a AML M4 specific subtype called as EO. So, in AML M4 EO, you are going to have lots of eosinophils, and that is associated with inverse 16. So, three characteristic translocations we had seen till now. First one was 821 translocation seen in M2. Second one is translocation 1517 seen in M3, which is APML. Then the third one is inverse 16 seen in M4. So, M2, M3 and M4 are associated with specific translocations. And whenever you see these three translocations, it is diagnostic for acute leukemia. So, even when the blast count is going to be less than 20%, you can still call it as an acute leukemia when you see these three translocations alone. Okay. Moving on to M5. M5 was acute monocytic leukemia, and this is the most common leukemia which we see in most common acute myeloid leukemia, AML, seen in infants. So, in infants, what is the most common AML? It is M5. Okay. And in this M5 is usually characterized by the presence of gum and skin infiltration. So, they will usually come with the mass in the gums and skin. Okay. So, gum and skin infiltration is common in M5 again. Then M6, if you see, already I have mentioned, it is the pure erythroid leukemia. So, erythroid leukemia was positive for PAS, which had a diffuse kind of positivity. And the immunophenotype of M6 is going to be CD71, which is also called as the glycophorin A. So, if you remember, glycophorin A is one of the proteins present in the RBC membrane. So, it is even the maximum, most abundant abundant protein present in the RBC membrane. So, glycophorin or CD71 is going to be positive in AML M6. While AML M7 is going to be positive for CD41 and CD61. So, don't confuse between these three. So, CD71 is going to be for AML M6, while CD41 and CD61 is going to be positive for present in AML M7. So, AML M7 is the megakaryocytic leukemia, which is the least common one, and it is going to be seen in Down syndrome less than 2 years of age. Okay. Now, let's move on to the WHO classification. Till now, we were seeing the FAB classification of AML. Now, we'll see the WHO classification. So, WHO classification, we are classifying it into 6 categories firstly. So, the first one will be AML with recurrent genetic abnormalities. So, recurrent genetic abnormalities in the sense, their translocations or the genetic event is going to be diagnostic for them. So, translocation 821 was associated with M2 subtype, 1517 with M3 subtype, inverse 16 with M4 subtype, right? Corresponding translocation with the FAB classification. So, these three, and then AML with NPM mutation, which is NPM is nothing but nucleophosphine. So, nucleophosphine will be positive in this mutations. Then there is something called as AML with biallelic SEPA mutation. So, all these 5 are going to be associated with good prognosis. So, when they ask good prognosis, it is these 3 translocations. Apart from that, nucleophosphine mutation and biallelic SEPA mutation. These 5 are going to have good prognosis. Other than that, we also have many other translocations. You don't have to memorize everything. Just remember, translocation 11q23 is going to have a bad prognosis. Okay. Then the second category will be the AML with myelodysplasia related changes. So, as the name suggests, there is going to be some kind of myelodysplasia. So, already I mentioned MDS can transform into AML. So, with myelodysplasia, in the sense, there is going to be dysplasia in the myeloid cells. And for calling it as AML associated with the myelodysplasia related changes, we'll have to have a dysplasia in more than 50% of the cells, at least involving 2 myeloid lineages. Okay. And they'll have to have the characteristic cytogenetic abnormalities which we see in an MDS. So, those will be usually deletion 5q, monosomy 7, trisomy 20 and so on. Okay. So, these kind of cytogenetic abnormalities associated with MDS should be present in the AML as well. And this AML with MDS is going to have a very poor prognosis. Then therapy-related myeloid neoplasm. So, when I was discussing the risk factors for acute leukemia itself, I mentioned about the alkylating agents and the topoisomerase 2 inhibitors, right? So, those two can drugs can cause both MDS as well as AML. Okay. So, alkylating agents usually have MDS related cytogenetics, and they usually have a 2 to 8 year period of latency. So, they'll become MDS and then transform into AML. Then in topoisomerase 2 inhibitors, they usually have a very short latency period of 1 to 3 years. So, after using topoisomerase 2 inhibitors for some other cancer, within 1 to 3 years, the patient will develop an acute leukemia, acute myeloid leukemia. And here it is going to be associated with translocation 11q23. So, already in recurrent genetic abnormality, I mentioned translocation 11q23 is going to have a very bad prognosis. As such, both the therapy-related myeloid neoplasms, be it an MDS or a AML, both of this is going to cause a very poor prognosis. So, both the myelodysplasia-related changes and the therapy-related myeloid neoplasms are going to have poor prognosis. Then the next category will be the AML NOS, which is basically the FAB classification. That is, they don't fit into any other category, so they are put into the NOS category, which is the FAB classification. Then the myeloid sarcoma, which is nothing but the chloroma. So, I already mentioned, if you see a chloroma, even without blast percentage more than 20% in the blood, you can still call it as acute myeloid leukemia, because there is going to be myeloblasts only present in the chloroma, right? Then the sixth category is the myeloid proliferation related to Down syndrome. So, in Down syndrome, we are going to have 2 types of myeloid proliferation. First one will be the transient abnormal myelopoiesis. Then next one will be the AML M7. So, the transient abnormal myelopoiesis is the most common hematological abnormality associated with Down syndrome. Remember, while reading genetics, we read this. AML M7, again, it is going to be in less than 2 years of age, right?